joining us live. Many of us don't need any introduction to Dr. Ron Jacob. He has been coming for many of the IACI meetings, and he is very closely associated with the IACI. He's going to talk to us about cardiac MRI, nuclear, and genetics. Thank you for joining us. Are you able to?
I'm sorry for interrupting for just a moment. We just need to felicitate Dr. Vinod since he has to go. Sir, could you please come up on the dais? Aparna?
Hello, Dr. Ron. Yeah. Dr. Ron, can you hear us? Sorry, we are not able to hear. Okay. No. Are you able to hear us? Yeah, okay. He's able to hear us. We are not. No. Sir, can you just unmute and mute yourself again? Mute, unmute again. We are not able to hear you.
Can you hear me now?
Yes, yes, it is clear now. Thank you. So,
Okay, very good.
Dr. Ron
Um,
has been.
yes, can you hear me now?
Yes, yes, we can hear you. Yeah.
Okay, very good. I can get started, and can you see my screen?
Yes, we can see your screen.
Okay, very good. I
We
can
are,
get
we are,
started now if
we
that's
are,
okay.
we are missing you here, sir. Yeah, it is.
It's a long journey. I
Yeah,
wish I could visit more often, but
sure. Yes, yeah,
uh, it's a long journey. So, but you never know. Soon, hopefully soon, I can make a visit over there.
sure. Yeah.
Um, so shall I get started then?
Yes, yes, yeah.
Okay, very good. So what I wanted to do with this talk was just to uh, uh, focus on multimodality imaging and specifically with PET, PYP scanning and CMR and how to integrate the two modalities. Where it ties in, we've had two great talks on genetic testing and cardiomyopathies. I wanted to focus on sarcoid because sarcoid can pretty much look like anything, and it's generally one of these diseases that it's called the great chameleon because it can look like a genetic cardiomyopathy, it can look like coronary artery disease. So just leveraging different modalities and using multimodality imaging is what I was hoping to do in this talk. Um, and hopefully provide some guidance in terms of how to navigate this. These are my disclosures. And I wanted to start off with a patient. This is a 59-year-old female presented with presyncope, bradycardia, EKG. The prior EKG was normal in terms of the PR interval. And then she was admitted with a very slow heart rate and was found to have a advanced third-degree heart block. The past medical history was significant only for hypertension, obesity, and NASH. This is our echocardiogram, slightly thickened valves, overall normal function, Doppler, not really showing anything. The LV function and looks like it's preserved. I would have probably given contrast. In fact, we did have contrast images, but the EF was 55 to 60% with contrast. The right ventricle, as you can see, is not well visualized. Overall, in summary, you have this patient with not much in the way of a past medical history, comes in with an advanced heart block, relatively young to have conduction system disease and a preserved ejection fraction. So really the question is, what should we be doing in these patients? And, when you see conduction blocks in a young patient, that should always raise a red flag. This paper was looked at that very question. What do you do with these patients with advanced atrioventricular blocks in middle-aged adults? And it occurs in sarcoid, interestingly, in 23 to 30% of cases. So, when you see this, that's, you should, in the back of your mind, you should think about either sarcoid or giant cell myocarditis. And this particular series, patients were between 18 and 55 years. And the incidence of sarcoidosis or giant cell myocarditis was 19% and 6% respectively. Now, interestingly, 39% of the patients with giant cell myocarditis or sarcoid experienced some adverse event, and that was when you compare it to the controls only had 2% of events. So just something to keep in the back of your mind. So in thinking about this, what do we need to answer with cardiovascular imaging? It's first of all, what testing do you pursue, right? I mean, somebody comes with presumed sarcoidosis, and in India, TB is going to be your great mimic, right? So, but generally, TB is usually evident in the clinical context in which you see it. Sarcoid can sometimes be very difficult to diagnose because it has a variety of ways in which it presents. So which test to order first? Do you order MRI, PET, and when do you do both? What's the diagnostic accuracy? And that I'll go into that a little bit later on in the talk. And how do you prognosis, biopsy, and therapy? How does imaging help guide all of this? So let's go start with which test to order first, and if any. And this is a really nice consensus paper that I've found to be very helpful. And for the large party, if you look at their approach, they feel that CMR is preferred, but you also have the option, if you don't have a center that has CMR, you can do FDG PET. The way to look at this is perhaps for the initial foray, if you're looking at a cardiomyopathy and you're not sure what they have, the CMR offers a broader, looks at function valves, LGE, you get parametric mapping, and can perhaps point you in one direction or the other. However, not all centers have CMR, and sometimes you might have to start with PET if you suspect cardiac sarcoid. So, and then you follow, down this. If it's normal, then you're generally reassured that if it's completely normal, you're generally reassured that they don't have anything. But if they have CMR, then you still have the option to go back and layer PET if needed. So this is our patient CMR, and you can see the right ventricle quite well, normal LV function, no regional wall motion abnormalities. Things to look for is that septal thinning, any focal wall motion abnormalities, focal wall motion abnormalities of the right ventricle. But this looks, in my estimation, this looks quite normal. So the EF, right and left ventricular ejection fraction is normal. The end-diastolic volumes are normal. Moving on to the STIRS, the short tau inversion recovery, and as most of the people in this audience know, this is a triple inversion recovery sequence, leverages the signal that you get. Water will have a bright signal. Fat is suppressed, and the blood pool is suppressed. And so here, if you look at the basal, mid, and apical slices, you can you get a sense that there's perhaps a higher signal in the basal anteroseptal and the mid-anterior wall. And then these are our parametric maps, and there's corresponding to those areas, you have an elevated T1 and T2 value in the basal anteroseptal and the basal anterior wall. So this is this paper that looked at the diagnostic performance of just native T1 for cardiac sarcoid that was published in 2020. And I'm this recurrent theme where I will tell you that abnormal scar or LGE is probably going to be your best predictor of VT, whereas the edema is more a sign of acuity or inflammation. But that's a broad brushstroke. There's gray areas in between that. In this particular paper, an increase in the extensive T1 greater than 2 standard deviations, but not 2 T2 values. T1 was more a better discriminator for impaired strain and LV ejection fraction in this paper. The strongest predictor, at least in this paper, for prediction of overt CS was a native T1 greater than 2 standard deviations in 3 segments. So this was a patient's LGE, and it's really important to kind of integrate everything: wall motion, your stirs, your maps, and then look at LGE. And so you have this typical, epicardial to basal anterior, and I don't have the basal anteroseptal slice here, but the basal anteroseptal slice also had involvement, and the basal infralateral segment, patchy involvement. This could be either myocarditis or suggests an inflammatory process with the T1, T2 markers. So putting it all together, you have, a cine for morphological abnormalities, this LGE for cell necrosis and fibrosis, T1, T2 mapping for edema and fibrosis, and the STIRS really looking at leveraging water content and as a secondary or surrogate marker. But if you have maps, generally, you may not need the STIRS. You can just use your maps. So that's the first, algorithm in terms of, what testing to use and which test to order first. We went with CMR because based on that algorithm, we felt that it would have given us the most information for a single test. So complementary testing, this is again the same algorithm, and even with CMR in a patient like this, you suspect sarcoidosis. The PET will help you in terms of your inflammatory burden and perhaps guiding therapy, and go into some other pieces of information that PET is helpful with. So these are PET basics, and most of the people in this audience, again, are probably very familiar with this. But under fasting and aerobic conditions, long-chain fatty acids are the preferred fuel in the myocardium, as they supply about 60 to 70% of the energy for the working heart. About 15 to 20% comes from glucose. The breakdown of fatty acids in the mitochondria is through beta oxidation, and it's exquisitely sensitive to oxygen deprivation. So when you have reduced oxygen supply, the myocytes compensate for the loss in oxidative potential by shifting towards glucose as an energy substrate. FDG, when you use FDG for PET, it enters myocardial cells by the same transport mechanism as glucose. And once it's in the cell, it's phosphorylated to FDG 6-phosphate. And because the phosphorylation is slow, it essentially becomes trapped in the cell, and it allows you to image the cell. And the cells that use FDG, and these are fundamental concepts, are cells that are ischemic or cells that are inflamed. So keep in mind that just because you see FDG uptake doesn't mean that it's an inflammatory cardiomyopathy. You could have ischemia in the LED distribution, for example, that would show FDG uptake. So moving on, this is the patient's perfusion imaging. And you can see here, what we're looking for here is a perfusion defect. Generally, with the rubidium, you're looking for a perfusion defect in the same area as LGE. I will say that LGE is more sensitive for the involvement for cell necrosis or scarring than rubidium. And rubidium, it's a fundamental property of the resolution of PET that you may not see the perfusion defect unless it's larger and transmural. So this is the patient's FDG, and you can see avid FDG uptake here in the same areas that you saw the late gadolinium enhancement. That's the basal anterior basal infraseptal wall. And there's also uptake in the spleen and the lung, which you may not, actually you can see a spot here and a spot in the spleen. So a few things about FDG that I think it's important to remember. Remember that, as I pointed out before, FDG can occur in other conditions other than sarcoidosis. If it's in a coronary distribution, make sure you exclude CAD. There are patients that we've had FDG studies on that we thought were ischemic, and we had them capped and they had obstructive disease. Non-cardiac settings, if you see FDG uptake in multiple areas, make sure you rule out, think of malignancy, because malignancies can have FDG uptake in multiple settings. Remember that what I said before, the resolution of PET is around 4 to 8 millimeters. LGE, breath hold LGE is about 1.5, a segmented breath hold 1.5 millimeters. So it's really better to pick up scarring or involvement with sarcoid, very subtle involvement with sarcoid. Lateral wall FDG is non-specific and not certain why this happens, but it's a well-observed phenomena that you see sometimes. It may relate to wall stress, but that you see FDG uptake in the lateral wall. Always if you have isolated cardiac sarcoidosis with no other involvement, just be thoughtful and look back and make sure you're not missing something else. So how do we make a diagnosis of sarcoidosis? This is a paper that looked at meta-analysis of all the different scar patterns and scar types, and there are certain classic descriptions of sarcoid, right? You have this hook sign where you see the RV involvement, adjacent RV involvement encroaching onto the LV. And then you have this sign in the mid infraseptum or the basal infraseptum. It looks like a triangle called triangle sign. But you can also have sarcoid that looks like a coronary artery disease or an infarct, right? So just remember that there's a couple of broad rules of thumb. Septum is almost always involved. If you don't have septal involvement, while it's theoretically possible, you should again look at things very carefully. Why is that important? We just had these talks about genetic cardiomyopathies, right? If you look at these, some of these look very much like sarcoid. If you look at this looks like that basal ring pattern, which is unlikely. But if you look at some of these and you keep looking at them, sometimes it's hard to distinguish them. And some of these desmoid plaque cardiomyopathies will be hot in FDG. They'll have FDG uptake. So always keep that in the back of your mind. So this is so how do we make a diagnosis of sarcoid, right? It seems to be the biopsy yield, as you know, is quite low. It's 20 to 30%, if that, because it's patchy disease, and it's not, the yield isn't particularly high. So this is the HRS modified consensus. It's based on the Japanese World Health Ministry criteria. So going back to our patient, she came in with, so what they want is the two pathways that they propose are obviously a histological diagnosis of sarcoid from myocardial tissue, which makes your life very easy. However, that's often challenging. In the absence of that, then you can follow the second pathway. And if you have, for example, a histological diagnosis of extracardiac sarcoidosis, and you need one of the following, and one of the following is EKG criteria, which the patient had advanced heart block. You have PET uptake and LGE. the imaging does form a pretty robust portion of this diagnostic algorithm. And it's really important here. They have that other cause of cardiac manifestation excluded. In this particular instance, I showed you that slide with genetic cardiomyopathy because you always want to keep that in the back of your mind. This paper, suggested that even with preserved LV function and patients with established sarcoidosis, cardiac involvement was present at about 19%. So the normal EF, as in this patient, doesn't really exclude cardiac involvement with sarcoidosis, meaning a normal echo with normal EF may not really answer your question. The inner third of the myocardium is what preserves your left ventricular ejection fraction. And in this paper, the sensitivity of the Japanese World Health Ministry criteria wasn't very robust. Moving on, what is the diagnostic accuracy? This comes up, right? PET and CMR. If you want a broad brushstroke, I think CMR is probably a little more sensitive, meaning you can pick up subtle disease for the reasons I mentioned. And PET is probably better for following disease activity and inflammation. The reference standard that everybody uses, the Japanese Ministry of Health and Labor Welfare criteria. But the problem with that is it's as I showed you in the previous paper, it's not as sensitive or as MRI or PET. Biopsy the yield is poor because of sampling bias. It's patchy, so you may. We had a patient where we did 8 samples and 1 of the 8 came positive. CMR, a normal CMR is reassuring, meaning it's very sensitive. And even if they have sarcoid and they have no LGE, generally their prognosis is probably going to be better than somebody with LGE. And when you compare it with the if you compare it to a brass standard, not a gold standard, the World Japanese Ministry of Health criteria, the sensitivity is about 100% and the specificity is about 78%. Moving on to the last 3 pieces, the prognosis, guiding biopsy, and guiding therapy. The yield is low if you do an unguided biopsy. However, with imaging, there are 2 ways that you can leverage imaging to increase your yield. The first thing is with PET, you can find extracardiac sites of biopsies. For example, this patient has a spleen or lymph nodes if they're big enough. Those are potential targets for biopsy, and they provide an opportunity to make a definitive diagnosis. And then you can also do biopsy guided by voltage mapping. Patients with a lot of septal involvement, and if the voltage mapping is grossly abnormal, that can form a guide or an area that you might want to, that can choose to biopsy that will increase your yield. What about prognosis? And this has been well established. This paper was published in 2022. It's 504 patients. So there was split into pathology rare and pathology frequent patients. So if you had patients with abnormal LVEF but no LGE, they generally tended to do well as opposed to patients with LGE, regardless of LVEF. And that's a consistent trend that if you look at this population, if you have normal LVEF and no LGE, you have no arrhythmic events or heart failure. Whereas if you have pathology frequent, a lot of LGE, you had VT, ICD shocks, and in these patients with no LGE and abnormal EF, they had heart failure, but no arrhythmic events. So that's just a broad brushstroke thing, how you can leverage the LGE and the findings on CMR to kind of have a conversation with the patient. This is another paper that was published in 2016, essentially saying the same thing, that 20% of patients had LGE. If you didn't have LGE, if you look at these curves, if you didn't have LGE, you did reasonably well, very low chance of events. If you had LGE, you had a reasonably high chance of events. So couple of pearls here that I will tell you. The extent of LV dilation dysfunction are obviously important predictors of survival. So the LGE individually predicts a higher risk of VT and of death. There's really not too much value in following the LGE. Once you have a certain burden of LGE after treatment, following that really not too much value because it remains relatively unchanged. Your risk of VT is predominantly mediated by that. Patients without LGE, are generally have a low risk of events. And remember that one point that independent of EF, the LG will predict adverse events. Right ventricular involvement is another sign of another index that will increase your chance of having adverse events. So a couple of points. Moving on to, so we focused on the workup, what test to order, what the sensitivity of the tests are, how it aids into the diagnosis, how the modalities can be complementary, how they inform prognosis. What about therapy? So imaging does have a very significant role in guiding therapy as well. The Delphi study looked at immunosuppressive therapy for sarcoidosis and specifically looked at FDG activity to guide therapy. And it suggested that immunosuppressive therapy may be considered in these patients with presumed sarcoidosis. ICD may be considered if the EF is less than 35% after immunosuppressive therapy, 35 to 40% if there's extensive LGE. Now that's a 2B recommendation, but the definition of extensive LGE, what is extensive LGE? I think we all know when we look at something, what is qualitatively what's extensive, but that wasn't specifically defined. So FTG is also useful in monitoring the response to therapy after you start something, after you start immunosuppressive therapy. So this is an algorithm that they've come up with. If your PET's positive, start immunosuppressive therapy, and you have a confirmed diagnosis of sarcoid or high clinical suspicion, start immunosuppressive therapy, repeat FDG PET, and if there's a reduction in FDG PET uptake, then consider tapering the immunosuppressive drug. Now, what does that look like? This is a patient with extensive uptake in the base corresponding to LGE with perhaps a perfusion defect, and this is what it looks like after immunosuppressive therapy. There's a persistent perfusion defect, which you will see often in the burnt out sarcoids where you have a persistent perfusion defect, but the inflammatory component is gone. So just summarizing really quickly, the yield with endomyocardial biopsies, low integrating clinical features, imaging findings, genetic testing, and following a multidisciplinary approach can be very helpful in making the diagnosis. PET-CT can guide therapy. You can use CMR as your initial diagnostic modality, and imaging can also help you talk to your patients about what they can expect in the future. I'm going to switch gears a little bit to this patient to a different phenotype. 63-year-old male with essential hypertension, dyslipidemia, AFib, heart block, non-obstructive coronary artery disease in the past, presented with chest discomfort and shortness of breath. We did a coronary CTA. He has some non-calcified plaque, but largely non-obstructive. And this is his echocardiogram. There's some LVA septal knuckle with flow acceleration in the LV outflow tract. And the echo suggested a gradient with Valsalva in the LVOT and the presumed diagnosis of hypertrophic cardiomyopathy. And this is why CMR in somebody with presumed hypertrophic cardiomyopathy, if the echo has presumably made the diagnosis. I think this is from the 2014 ESC guidelines suggesting that accurate assessment of wall thickness is best made by CMR, especially in the basal anterolateral segment or the basal anterior segment that's often missed or underrepresented by echocardiography, and interstitial small aneurysms can be missed. Remember that MR plans images of a it's truly three-dimensional. You plan your planes or prescribed planes based on three-dimensional information. So you rarely have true four-chamber, a true HLA, VLA, and not sometimes you're not foreshortening the image if you do it correctly. So this is just underscoring that apical aneurysm, you can miss them as up to 40% of patients. And in addition, CMR provides tissue characterization, which is really important. This is our patient's CMR showing, significant LVH, obviously, long anterior leaflet, systolic anterior motion with septal contact, septal to anterior leaflet contact, and obviously LVH. So a couple of pearls in a HOCM, look for, it's not just LVH, you need to look for apically displaced pap muscles, myocardial crypts, mid-cavity obliteration, apical aneurysms, and the length of the anterior leaflet. Really, really important. This is the patient's LGE, and his maps were extremely high. He had this diffuse, now you can see, obviously see LGE in hypertrophic cardiomyopathy, but this kind of diffuse pattern, we thought it was soft and diffuse and little more than we expected for a diagnosis of hypertrophic cardiomyopathy, very high T1 values. We went ahead and considered cardiac amyloid, and I'll go through this quickly in the interest of time. But since we're talking about genetic cardiomyopathies, this is very much a genetic cardiomyopathy. There are two main types, and we were talking about protein deposition and the mRNA coding for a protein that's dysfunctional, and this is a classic example of that. And you have two main types. You have the AL, which is an immunoglobulin, is secondary to light chain amyloidosis. And then you have the ATTR variant, and the ATTR variant has two types. There's a wild type strain and a strain that's not the wild type. One other important mutation that we talk about here, at least, is the V122L mutation seen in African Americans, and about 3 to 4% are heterozygote carriers. Now, a couple of things. The low-grade and severe aortic stenosis, there was a recent publication by Joel Cavalcante suggesting that about 20% of those patients or more will have amyloid, ATTR amyloid. And 25% of elderly patients on autopsy have ATTR. Couple of flags clinically. Who do you look for this? Again, going through the same process. Who do you go look for this? Low voltage EKG, thickening of the ventricle, intolerance to ACE inhibitors, bilateral carpal tunnel syndrome. There's a publication suggesting that those patients you should think about looking for amyloid. There are obviously different clinical phenotypes or different clinical. The people who present with AL and the patients who present with ATTR are two different populations. So the clinical history is really, really important in determining which way you would think about it. This is the testing algorithm. In short, like this patient, if you're thinking of an infiltrative process or HCM, which is often the case, CMR is usually your best bet. If you're not thinking of that, and if you're predominantly thinking of just amyloid alone, you can do a PYP scan, which is very sensitive and specific. And this algorithm is quite helpful. But once you make a diagnosis, if this is positive, then you still, there's a high chance that it is ATTR unless you're grade 1 uptake, at which point you could still have AL. But genetic testing is very important in this case because once you identify ATTR-CM, you want to determine whether it's the wild type strain or ATTR-V. And it's critical because the ATTR-V should trigger genetic counseling and potential screening for family members. And the identification of I mentioned the VL122 mutation. that suggests aggressive progression meriting closer follow-up. And certain therapies are only approved, like if you want to prescribe tafamidis, that's only approved for ATTRV. So again, genetic testing here is important um, value in identification of your family members, or prognosis, and therapeutics in this particular instance. So just really quickly, I'm going to finish up here with PYP scanning. It was first used in bone tracer bone scans, the radio tracer. It's been used for a very long time, since 1982. And the utility was first noted when they saw myocardial uptake in 10 patients with tissue-proven amyloid. The specificity and positive predictive value are near 100% if you have grade 2 or grade 3 uptake. What does that mean? Here's bone. This is the planar and the SPECT images. Here's bone uptake, and you're looking for uptake in the myocardium. Generally, the planar really adds not that much value if you have a good SPECT CT. You can see here that grade 3, it's brighter than bone. Grade 2 is as bright as bone. Grade 1, you can see something there, but it's not as bright as bone. And obviously, grade 0, you don't see any uptake. This is our patient's PYP scan, which is grade 2. Grade 2 or grade 3, which is very suggestive of ATTR amyloid. He went on for genetic testing, had ATTRV, and he'll probably be evaluated for tafamidis in our heart failure clinic. So in summary, CMR and nuclear imaging can be complementary modalities. You have to understand the limitation and strength of each modality and leverage the two. I've had several patients that have dual pathology. The elderly patient who comes to me for viability, and yes, I see a subendocardial infarct, but there's a diffuse soft pattern in the base that makes me think they also have concurrent amyloid. And then the PYP scan is very helpful. A couple of other tips. Sometimes the right ventricle lights up on PET, and you have to go back and look at your CMR. LG in the right ventricle is sometimes very hard to pick up and detect. The basal infralateral wall LGE is, again, when you have that soft finding, it's much more apparent on PET sometimes. So you go back and look to see is there some subtle LGE there. So you can leverage the two modalities and kind of train your eye that way. And as I hopefully made a case, it's helpful in the diagnosis, in prognosis, and in treatment. And always keep genetic testing in your back pocket because you might need that to clinch the diagnosis. There are some desmoplakin mutations, for example, will look very much like sarcoid. Will also have a hot, the PET scan will also light up, and it's hard sometimes to distinguish. And you've got to look at the EKG, the clinical picture, whether there's any extra cardiac activity to kind of really make a diagnosis. All right, I'll stop there, and I will take questions.
Thank you, Dr. Ron. That was an excellent talk. And I have two questions before we open the questions to the audience. One is about CMR positive and, CMR negative and PET positive cardiac sarcoidosis, which is the talk of the hour. And the other one's about the importance of atrial scar on MR in an MRI in cardiac sarcoidosis, or atrial involvement in PET in cardiac sarcoidosis.
Yeah. So the CMR. Let me take the first question first. So the CMR negative but PET positive sarcoids. Was that the first question?
Yeah.
Yeah. So to me, that I would look at that very carefully and see, why that is. For example, if your maps are completely normal, your parametric maps are completely normal, your STIRs are normal, there's no LGE and normal LV function, I would make sure, first of all, that you're adequately suppressed. Your FDG, uptake, your dietary prep is good, and you're adequately suppressed, because we're seeing more and more that the non-specific, the basal ring pattern, for example, the lateral wall uptake, and there's certain patterns that we see. It's not clear to me that why some people have are unable to suppress the FDG even with adequate dietary prep. I would look at that very carefully, and make sure that we're not having FDG uptake for some other reason, B, for an inadequate dietary prep, and C, whether it's FDG uptake in a pattern that is uncertain or non-specific. The other piece of that is, if it's purely isolated cardiac, is it theoretically possible to have isolated cardiac sarcoid? But I would look at that very carefully, without any extra cardiac uptake at all. So that's how I would approach that. And we discuss all these patients in a multidisciplinary clinic. We have a rheumatologist, a pulmonologist, myself, geneticist, and we put everything together. And sometimes, you have to look at everything even without biopsy. You may decide to treat and see how they do with treatment if it suppresses the activity. But I would look at that with a jaundice dye. And the second question was atrial uptake. Yeah, I've seen that a few times. I'll start with a scar by MRI, and you have two camps in SCMR. Or two camps in the MR community: people who believe in atrial scar and people who don't. The atrial wall, now your average your resolution with a segmented LG is about 1.5 millimeters. The atrial wall is about, on a good day, it's 1 to 2 millimeters. If you have AFib and an atrial myopathy, maybe it'll get to 2.5. So just basic, physics. You see that not infrequently. When you see it, you see it, but often you're looking at it and you're squinting at it and making sure whether it's real or not. So that's by MR. By PET, we see it not infrequently. We see it in the right atrium, we see it in the left atrium. What does that mean? There's one or two small publications about it. What does that mean? Whether it provides additive value, I'm not sure. Do they have some atrial myopathy? I think probably if they have, that would be a marker for atrial arrhythmias, but I can't prove that, and I don't have data. We don't have enough patients to support that. Now, the other thing I will tell you, we've seen patients who the activity in the myocardium gets better, but their lymph nodes are still active. So it's a field, it's a growing field. I think integrating PET, the future is integrating PET and MR together, because like I said, if I see a completely normal MR and the PET is positive, I look at that with a jaundice dye. If I don't see septal involvement, anything's possible, but I really want to look and make sure that we're not missing a desmoplakin mutation, we're not missing something else.
Thank you.
Does that answer your question, Ashita?
Yeah, thank you very much. This is actually regarding a doctor, a colleague of mine who I scanned, and then he came in with the arrhythmia, and then I did an MRI, and then, it was bang normal. Strain was normal, atrial strain was normal, everything was normal, mapping was normal, because it was, the EP cardiologists were, have been looking at a few PET positive and CMR negative scans, and have been reading up about it. So they decided to send him for PET, and then that came out to be positive. With
where was? I'm sorry. Where was it positive? Out of curiosity, which wall was it? Diffuse or?
No, it was not diffuse. It was not diffuse. But then we did, first tell them that let's just get it reviewed by someone we know, so that we know that it's not an artifact that we're looking at. It was patchy, and it was not just in the basal anterolateral wall. And there was a small lymph node which took up, FDG, and we went and biopsied that through EBUS, and then that came out to be sarcoid.
Oh, that's like we live and we learn. That would be. I'm sorry?
Yeah, so non-caseating granuloma. That's what happened. And there was a colleague of ours So we're like, okay, that's when we started thinking, and this is something recent. So, yeah.
That is worth publishing because having a completely normal MR with and maybe it's just very very early disease you were able to pick. And what was the initial manifestation?
Just palpitations. And
Okay, so
yeah, so it was
okay.
not even 80 blocks. It wasn't, he was otherwise not, I think he had one episode of syncope, but that's it. Like, he just thought he was tensed or stressed out or something like that, and he just decided to go, and they found some VPCs, and then on Holter, the usual workup, and this is what happened.
Yeah, that's really interesting. Usually the VT is mediated by the LGE, the inflammation not so much, but you can get conduction blocks depending on where the inflammation is. So it would be interesting to follow that up with a repeat CMR. And so what did you do for treatment? Did you put him on immunosuppressives or?
Yeah, he is on immunosuppressive.
Okay. Yeah, it would be interesting to repeat the CMR in about 6 months or so, see if something changes.
Yeah, we'll get back to you on that. So anyone in the audience?
Hi, can you hear me? Hi, Ron, it's Vanessa here. How are you?
Hey, Vanessa, how are you?
Okay, great. I wanted to ask you, so do you think from the algorithm, it says, okay, if you have an abnormal, if you suspect sarcoid, sarcoid, and you have an abnormal CMR, you should then go to do the PET. Do you think that, the CMR is not good enough to just move on to treatment, decisions, or is there something still not quite right about CMR in its current state for doing that?
Yeah, so that's a great question, Vanessa. So, so CMR will give you everything as a baseline. However, I think for follow-up after immunosuppressives, the PET gives you certain quantitative markers that I don't think are as mature in CMR. So we do a max SUV, and there's vagaries with that. I mean, whether you follow the max SUV or whether you follow a total SUV amount of inflamed mass, that I find is probably qualitatively easier to do by PET. But Vanessa, till you publish stuff about T1 changes in T1 and T2 that'll help us guide therapy, then I think it's going to be it's easier to do with the or it's there's a I think there's more support or literature with PET to guide therapy. So I need a baseline. When you see a baseline, like the patient I showed you with which was really really bright, and then they sometimes a dramatic response to the FDG uptake.
Okay, so basically we need to generate more evidence from the CMR point of view, maybe using quantitative mapping and follow longitudinally over time and see how it compares to, maybe PET, and go from there.
Yeah, I guess conceptually that would seem to be an elegant, where you have a value and a change in say, 10, 15% your T1, T2 values would correspond with a meaningful change in therapy to guide, because we in the sarcoid clinic we actually make either based on the PET findings we either increase or escalate our immunosuppressive therapy or scale it down or stop it. So those are, to tie that in with therapeutic decision making is really where it's at, and we have to have enough diagnostic confidence in the numbers to say, hey, we're going to stop your immunosuppressive, or we're going to escalate it and give you something that's potentially a little more harmful but may be beneficial.
Great. Okay, Ron, we'll get to work on all that
research.
No.
I'm sure you will, Vanessa.
Thank you.
I think we have a lot to discuss about in this topic. It's interesting and it's invigorating. So, so we'll end the session here. Thank you very much.
No,
and
if I can
okay, yeah. There's another question by Dr. Priya.
No, not exactly a question, because I also had a talk earlier in the day on this happened, and I was going through the literature and updated literature. So, like Dr. Ron said, I think the advantage of FDG PET is when you have a strong clinical suspicion and your cardiac MR is negative. We say cardiac MR is to rule out cardiac surgery. It's almost 100% sensitive. So, but in extracardiac sarcoid, so FDG PET has an advantage of showing that extracardiac sarcoid can help you clinch the diagnosis when you have a strong clinical suspicion of a negative cardiac MR. And second thing which Dr. Ron mentioned, that that quantitative assessment is something which our cardiac MR lacks. So that again is an advantage of FDG.
Thank you. Yeah. So thank you, Bai. Yeah.
I think, I think there's certainly complementary modalities, and there's, and I didn't, in the interest of time, I stopped, but the CMR also provides you valuable information about RV function, which in the sarcoids can sometimes be, and it's a prognostic. The two ways in which the RV is affected is the LGE, which is correlates with arrhythmia, but you also have pulmonary hypertension, RV dysfunction on that basis, which is a prognostic marker. I really feel, leveraging the two modalities as the field is growing, to provide the maximum benefits to our patients. And we're learning all the time. Our sarcoid clinics, all of our sarcoid patients get almost all of them will get a full gene panel done. We have Helix here. So it's an exciting new time to be in this field, because you're learning things that look like sarcoid, but sometimes end up being desmoplastin or other cardiomyopathy. So
absolutely. If you look at the earlier publications, when we didn't have the T2 mapping, then obviously for inflammation, FDG PET was supposed to be superior. For picking up fibrosis, LGE. But now that we have T2 mapping, we feel more secure with our diagnosis when we mention, edema and fibrosis put together.
But I still find it difficult I still have cases, I have T2 mapping. So when I do T2 mapping as well as look at stir, if the stir is of, iffy quality, then mapping, unless it's a diffuse, if it's diffuse, then you kind of end up getting meaningful mapping values. Otherwise, if it's just focal, focal edema, then how many ever ROIs you do, or if you do a global ROI on the myocardium, you don't end up getting, right? Like even mapping was normal in this.
I think we are using circle and we get the segmental map.
Yeah.
And that's very helpful actually. So,
So I think even in the CMR community, we're dichotomized with for mapping and against mapping. So yeah.
I'm going to hold my silence with Vanessa in the room. I would. She knows where I live, so I will have to be very careful about maps.
No, I agree. I think there's currently a shortcoming in the way we interpret maps, or the way we make the tools available to readers. It's not easy to read and analyze them. It's too cumbersome. It's too time consuming. It is something we need to work on to make it more accessible, more user friendly. It's not immediately visually diagnostic in many ways.
We do maps routinely in almost all of our patients, but we've also spent a lot of time doing our normals, establishing normals. We have a phantom, T1 phantom. So I think if you put in that work to make sure that your numbers are reliable and solid, and what your normal values are, then it's we found it to be helpful, quite helpful.
That brings me to another question here. So when should we be repeating our mapping values? We have a 5-year-old scanner, and we have a scanner which we got 5 years ago. We have given T2 mapping values. So the platform gets upgraded now and then. So should we be repeating our
That's an excellent question, because we know that mapping values can drift over time, correct? So sometimes the phantoms can detect that, and every time currently, there's no sort of consensus. Some people might do it yearly, or every time you change a software or a hardware upgrade, just to check. But I have to say that this is not done consistently. Wouldn't you agree, Ron? The checking of mapping stability.
Absolutely. That's so we as I was mentioning, we have a phantom. So anytime we make changes, I personally think, and Vanessa, I would defer to you on this, but we feel that if we make changes, software upgrades, we'll run the phantom again to make sure that our values haven't changed.
Yeah, that's right. I think that is a prudent thing to
And-
do. Yeah.
And the Phantom itself has a short shelf life, right?
Yeah. So we need to know that phantoms, they are gels and water. Gels dry over time; they will change. It's like your reference gold standard yardstick changes over
Yeah.
time. That's what you're doing. So our phantom in Oxford, it's not just a phantom. It's the whole QA process. It's a bit immune to the phantom aging. So
Oh,
we
wow.
don't need to change the phantoms whatever every year. Our process, the patent has just been granted. Our QA process is a little bit immune to this phantom aging process. It's the way we do the QA and the pass-fail, which currently isn't offered by other systems.
That's encouraging. No, Phantoms are currently the ones that are available commercially has a short shelf life and it's expensive. So no, that we've done. That we have to do as a process. We've done. But again, like how many times to keep doing the healthy volunteers, right? Yeah, that's what. So I mean, I think Vanessa's Oxford's Phantom is
Yeah, so for
encouraging.
instance, I'll just take an example. Let's say we have our Schmoly T1 mapping technique. We made it, it's in our system. We know that it works, and let's say we use our phantom, we check it, and it looks like it's within tolerance range. It passed. And so let's say I've done my healthy volunteers as well. I've done a bunch. I'm not going to repeat 100 healthy volunteers. That's crazy. And so then now when we upgrade the software or something happens to the scanner, I might stick the phantom in there and scan it, and then we analyze it. Did it pass or fail again? If it passed, then I'm reasonably confident that it's working okay. I'm not going to repeat 100 healthy volunteers. So that's sort of how we, approach this.
Can I ask you this final doubt? I've been discussing it with the last couple of hours. Phantom versus healthy volunteers. I want everyone else also to take this message. Phantom versus healthy volunteers. Either of which, both, or only one.
So the phantom doesn't give you the normal range. To get a normal range, you need to scan the healthy people to get normal human myocardial normal range. So the way we sort of do it is the phantom is to make sure that the method, the actual sequence, it's performing what it's supposed to do in the scanner. It doesn't spit out a normal range for me. To get the normal range, let's say I scan 50 healthy volunteers, let's just say that. And our sort of concept is it's like, okay, so let's say Oxford, I've done a bunch of healthy volunteers over time. I know what the normal range is. I know what the standard deviation is. And I have a phantom, and I know that my method works well. So if I were to give my method to you, Dr. Nuri, and I send a phantom to you and check that it works well on your scanner, it is hoped that you can just use my healthy volunteers as a reference range. You don't need to scan 100 yourself because your method is working the same way as my method. And that would be really good, for many centers, because a lot of centers cannot scan so many of their healthy volunteers and all the time. And so to do that, we need some support and collaboration from the industry partners. Like they need to help us to keep that method stable within their system, because if they change something in their sequence or the way it is programmed, we have no control over it as an academic center. So they kind of need to partner up with us and say, right, we need to keep this method stable. If they change something, we can't do anything about that, and then the values will change.
Final word I wanted from you as an authority on T1 T2 mapping is, I don't have a phantom. We don't have access to phantom because our companies don't help us in getting, they are blank. They say what phantom? So in such a situation, If we can still do a 50 or 100 cases normal range, for example, every year, we can afford to do it. We can afford to do it, we can afford to do it. Or 20, 40, 50 cases. Can we do away without phantom? Are we wrong otherwise? That is what I want to ask.
No, I don't think you're wrong. It's a very expensive and time-consuming way, to sort of do that. But yeah, you can do that, and then if the normal ranges are comparable, then you're reasonably confident that okay, they're kind of the same. But it seems quite time and resource intensive. Ron, what do you think? Like to be scanning so many healthy volunteers every year, I think that's a very high ask of centers to do that.
Yeah, I would probably let go from my post if I asked to do that. My administrators probably wouldn't let me keep working. But yeah, no, yeah, but that is a alternative way to do it. But the phantom just kind of really in my mind, the way I look at it, the phantom just tells you nothing's changed. When I agree with Vanessa 150%. You have to be militant with the vendors that they don't change anything. They don't change, So there's this whole idea between accuracy and reproducibility. The vendors want to make the sequence more and more accurate. Meaning, does it assess it to the millisecond? To me, what I want is a reproducible value. If it's 920 milliseconds, every time I repeat it, it should be pretty close to that. I don't need 920.2 milliseconds, in terms of accuracy.
And also, if the administrators are allowing you to scan 50 or 100 every year, like, that's so much more expensive than buying Phantom. Like, why do they, and we don't charge the Phantom. Like, we collaborate with people who just come and do it,
Yeah, I think there's one company, at least for us in Europe, that we had to get it from. You have to order it. It took several months to come, but
It's
might be
the
worth looking
Australian,
into.
the Australian company.
I'm sorry.
I'd just like to make a comment. Looking at it very practically and realistically, say you've done X number of volunteers and you've got your control, and you're doing mapping on a daily basis on every patient. So you have a feel on what your values are, and then you change your software or whatever, something you have done, and then you just continue using the same mapping, and if you feel that the values are going wonky, something has gone wrong, so then you need a phantom or you need his X number of volunteers again. But if your values are still continuing to fall within the range that it was doing before, do you still have to pursue such an aggressive phantom and the change of volunteers since phantoms are not available, etc.? What do you say, Vanessa? It is recommended, but I'm just saying practically we can't do many things that are recommended. It's not possible in real life.
I think it's not wrong. Like, it's just that there are tools that are being developed to maybe increase the confidence in these quantitative methods that are being done. But Ron, what do you, right? Like, I mean, many centers are just carrying on with life as is, and you know what I mean. It's just that we're developing new tools to ascertain, quality assure and quality control these things to make sure. But I can't say that it's wrong.
Vanessa and Ron also there is, if possible, try an algorithm where you do away with phantom, just probably 25 or 30 control.
So you talked about ECV being, different in males and females. So what about female mapping values? So we have 100 volunteers. So if I take a 20-year-old female versus a, say, 70-year-old female, same male and female. So do you think we should have a variety of sex and age and BMI related,
Yeah, yeah. Yeah, so if you so these are known physiologic parameters that affect T1 T2 values, sex, age, they affect the T1 T2 values. If you look at the SCMR nomograms, like normal values for various things, people have, let's say, the resources, and maybe they pull data so that they have normal values of LV parameters, RV parameters by decade, like 20-year-old, 30-year-old, 40-year-old, like this. I mean, again, it is a very difficult thing to ask centers to individually do all that, if the vendors would keep the method stable, then you can do it. But if it's changing all the time, then it's not really meaningful. Because the minute we publish it, everything changes, and then you can't refer to it again. That is the problem, because we need some collaboration and support from the vendors. Mm. Yeah.
So we'll break for tea here.
Yes.
A quick tea break.
Another, no, for another 5 minutes.